Let's talk about narrow complex tachycardia. What is narrow complex? Narrow complex means QRS is less than 0.12 second or less than 120 millisecond, less than 3 small box. So in narrow complex tachycardia, it can be regular, it can be irregular. If the narrow complex tachycardia is regular, what can be the causes? One can be sinus tachycardia. Second can be AVNRT. Third can be AVRT. Fourth can be atrial flutter with fast ventricular rate. And if it is irregular, then obviously atrial fibrillation with fast ventricular rate. So definitely if you see tachycardia and you don't see P waves and it is irregular, then you don't have difficulty differentiating whether this is atrial fibrillation or not, right? But here you can get confused in differentiating these 4 types of abnormality or arrhythmia, because you will tell that, oh, I can differentiate sinus tachycardia because there should be P wave before each QRS, there should be P wave before each QRS, P wave before each QRS, but it is not always. If the tachycardia goes very fast, what happens that this P wave can merge with this T wave and you can get only T wave. There may not be P wave, and if it is not a P wave, if there is no P wave, then it can be AVNRT, it can be AVRT, it can be atrial flutter as well. But in atrial flutter you will generally see sawtooth pattern that might help to differentiate, but you will have difficulty differentiating AVNRT, AVRT from sinus tachycardia. And the parasympathetic influence is on both sinoatrial node and atrioventricular node, right? So let's say you connected patient to ECG leads and you did vagal maneuvers, right? There are many vagal maneuvers. I won't discuss the vagal maneuvers in this video because it will be long. So there are variety of vagal maneuvers, like one is carotid sinus massage, right? So with excessive parasympathetic stimulation, if the AV node slows down, so when AV node slows down, then if you can see the P wave before each QRS, or P wave might be retrograde as well, then those suggests AVNRT or AVRT. If the vagal maneuver is not helping, then this is most likely sinus tachycardia. So you might be wondering, oh, vagal maneuvers, with vagal maneuver there is parasympathetic stimulation on sinoatrial node as well. So why does not it slow down or terminate sinus tachycardia with vagal maneuver? First of all, you have to understand why sinus tachycardia occurs. So if sinus tachycardia is occurring in an individual, it must be there should be underlying cause, right? Either can be hyperthyroidism or might be sepsis or whatever the underlying cause might be. So that is causing excessive sinus node activation. So that influence is greater than parasympathetic influence that you stimulate. That's why you won't see termination of sinus tachycardia with vagal maneuvers. But these AVNRT, AVRT can get terminated with vagal maneuvers, right? So that is one point that help you to differentiate sinus tachycardia. Now let's talk about AVNRT and AVRT. So AVNRT, so this is AV node reentrant tachycardia. So let's understand the conduction system. Let's suppose this is SA node, and impulse is spreading in the right atrium, it goes to the left atrium, then it comes to the AV node, and then it goes via bundle branches. Now let's zoom this AV node. So let's zoom in this AV node. You know, in AV node there is one fast pathway and there is one slow pathway. So in this fast pathway impulse travels very fast, but in this slow pathway impulse travels slowly. So this is normally present in normal heart. Like when impulse reach here, this travel in this fast pathway, this travel in slow pathway as well. But generally the impulse only travels in one pathway only. If heart rate is very fast, then it needs to be slowed down, then impulse can travel in slow pathway. But generally in a normal resting heart, impulse travels through fast pathway, and through this it comes down here, and then it goes via bundle branches and depolarizes the ventricle. But in atrioventricular nodal reentrant tachycardia, this impulse that is reaching here, it all goes downward, and this also goes backward. And when this impulse goes backward, it again excites this, then it again depolarizes down, and another impulse is again coming, then that causes tachycardia. Because this impulse that is coming down the fast pathway is not only getting down, but it is also reciprocating here in a circle, and that is leading to fast ventricular rate. That is the problem in the AV node reentrant tachycardia. So what they do, that they ablate this slow pathway. If you want to permanently treat this condition, you ablate this, burn this pathway with radio frequency, then the impulse that comes in this pathway won't go back in this direction, it only goes in this direction. But if you want to temporarily slow down the heart rate, you can do vagal maneuvers. If you do vagal maneuvers and activate parasympathetic nervous system, then the impulse that is reaching here gets slowed down, right? And when there is parasympathetic stimulation to the AV node, then this impulse that is traveling in this direction won't travel in this direction, and it can get terminated instantly. If vagal maneuvers is not helping, then you can also try adenosine. Adenosine also has same mechanism. It slows down the AV node and it prevents the re-entry of the current in the AV node. And you know, adenosine is expensive and it may not be available everywhere. So if adenosine is not available at your center, then you can try beta blocker, calcium channel blockers as well, because these also act in the AV node and this also helps to slow down the AV node. So this can also be helpful, but guidelines say use adenosine. If you do not use adenosine and you use beta blocker, calcium channel blocker, and if adverse outcome occurs in patient, then you will be liable, you can get sued. So follow the guideline, use adenosine. But I have also worked in rural part of my country, and we did not had adenosine and we had terminated with esmolol. So you know, esmolol also acts within 1 minute, so it is fast acting. So you can use esmolol, you can use metoprolol, propranolol as well. This also acts like in 3 to 5 minutes. So if your patient is not hemodynamically unstable and you can wait that much time duration like 3 to 5 minutes, then you can use diltiazem, verapamil, esmolol, metoprolol, propranolol. All those drugs will act within 5 minutes. So you can use this. And definitely if patient is unstable, hemodynamically unstable, then you have to do cardioversion, right? But I am telling you that we had terminated this AVNRT with beta blocker, calcium channel blocker, but don't try this if adenosine is available, because that is the first line, and we recommend to follow the guideline. Because if adverse outcome occurs or if patient files legal case against you, then there can be problem. So follow what is the guideline says. So that is about AV node reentrant tachycardia. Now let's talk about AV atrioventricular reciprocating tachycardia. So here the problem is not in the AV node. Let me draw the heart. This is the right atrium, this is the left atrium, this is the right ventricle, this is the left ventricle, this is SA node, and the impulse comes to the AV node, and this gets conducted through the bundle branches, fascicles, right? So here in this condition there is abnormal electrically conducting tissue between the atrium and ventricle. So this is not only in the left atrium and left ventricle, it can be in this side as well. But you know, this is the insulating tissue, this is a fibrous skeleton, and you know, conduction does not occur between atrium and ventricle except this point. So impulse current travels here and goes via this pathway. Other than that, there is no conduction between atria and ventricles. For synchronous contraction, nature has designed in that way. But if let's say there is abnormal conducting tissue, either congenitally or after a scar, after myocardial infarction, or after any heart surgery, because you know in cardiothoracic surgery they repair valve with open heart surgery, and if there is a scar formation or if there is abnormal conducting tissue formation between atria and ventricles, then those can cause AV reciprocating tachycardia. So normally impulse travels from AV node and down the conduction tissue. So if impulse comes down here and it depolarizes the ventricle and it loops backward through this conducting tissue, goes to the left atrium and again comes to the AV node, again goes down, then it causes tachycardia. So this is called orthodromic, because the conduction in this bundle branches fascicle is occurring orthodromically in normal direction, and it is going back with this electrically active tissue. So this is orthodromic. And there is another type of conduction also called antidromic, but 95% of the cases that we see is orthodromic. I have never seen any case of AVRT with antidromic conduction. Antidromic means conduction is occurring. I can remember now one case that I had seen of antidromic conduction, but it is pretty rare, like only 5% you can say. So what is antidromic? Antidromic means conduction is occurring, electrical activity is coming through this tissue and it is going back in this direction. So this is the normal conducting tissue. So in normal conducting tissue, activity, electricity is propagating in opposite direction. That's why it is called antidromic. So this anti and ortho terminology is given based on the conduction occurring in the normal conducting tissue in these bundle branches fascicles, not this abnormal electrical tissue, right? So if there is orthodromic AV reciprocating tachycardia, then you can terminate with vagal maneuvers and adenosine, beta blocker, calcium channel blockers, because if you slow this down, the impulse that is coming via this pathway will slow down, and it will not there will not be much impulse to go backwards and to create this vicious circle. But let's say let me draw another picture. So this is left atrium, right ventricle, left ventricle. So if let's say conduction is occurring in this direction and it is going backward in this direction via AV node. So if you give beta blocker, calcium channel blocker, adenosine, or if you do vagal maneuvers, what happens that if you block this AV node, what happens? All the impulses comes in this through this pathway, right? So it will aggravate the condition, right? You have slowed down the AV node, and AV node, you know, this is a gatekeeper, or you can say it is a brake. In car, there is a brake to slow down the speed. Similarly, this is a brake of the heart that slows down the impulse that is coming if it is fast. But if you slow down this, what happens that all the impulse that will come in this pathway, and it will excite the ventricle further and further, and it can aggravate it. So we do not give beta blocker, calcium channel blocker, or do vagal maneuvers in antidromic AV reciprocating tachycardia. We can use antiarrhythmic drugs like procanamide, amiodarone. We can use those. I have discussed these antiarrhythmic drugs, different classes, in another video. You can check if you want to know more about that. But we can use these drugs here, but do not use beta blocker, calcium channel blockers, or do not do vagal maneuvers. So it is important to differentiate whether this is antidromic conduction or orthodromic conduction, because you need to decide whether to give calcium channel blocker, beta blockers, or adenosine, or whether to try vagal maneuvers, right? So how do you differentiate whether this is orthodromic or antidromic AV reciprocating tachycardia with ECG? Antidromic AV reciprocating tachycardia. So here you can see in orthodromic, conduction is occurring through the normal conductive tissue. That's why QRS will be less than 120 millisecond. But since the conduction through this pathway is occurring, which is abnormal, and it is going through the ventricular myocyte, so here QRS will be wide, more than 120 millisecond, right? And here you can see, since the impulse is coming through AV node, there will be PR interval will be like 120 millisecond. This is the pause, right? PR interval, you know what is this PR interval? This is the pause of AV node. But here PR interval will be less than 120 millisecond, because there is no AV node between atria and ventricle. Impulse is directly coming to the ventricle, so PR interval will be less than 120 millisecond. And here you can see delta wave as well. Delta wave means like this is P and like Q. This is here, this is called delta wave, right? It is slurring. So if you see delta wave, then it suggests you antidromic AV reciprocating tachycardia. Right? And now let's talk about atrial flutter with fast ventricular rate. So let's draw the heart again. So this is the right atrium, this is the left atrium, this is the right ventricle, this is the left ventricle. So sometimes if there are ectopic sites exciting the impulse, like this is normally SA node fires and P wave arises, right? But if there is also this focus is firing, this focus is firing, this focus is firing, right? So there will be different types of P waves, like P waves can be like this type, or can be this type, or it can be inverted waves. So if there are different ectopic sites causing spontaneous electrical activity, and that is called atrial flutter, right? And if there are multiple such ectopic focus, then that is called atrial fibrillation. So in atrial flutter you can see like a little P wave, like, but in atrial fibrillation you won't see the P wave, you won't be able to detect P wave. It will mingle with the straight line, like it will disappear. It is so rapid. But you can say atrial fibrillation is a younger brother of atrial flutter, is a younger brother of atrial fibrillation. So if patient has atrial flutter, then in due course of time in future he can also go into atrial fibrillation as well, because atrial flutter is a milder version of the fibrillation. So if there is atrial flutter, so that is also exciting abnormal electrical activity, and that also travels down the AV node, and that also excites the ventricle. That's why there can be fast ventricular rate in atrial flutter as well. And this is narrow complex because conduction is occurring through the normal conducting tissue. The impulse is originating at different places, but the conduction is occurring through this normal pathway. That's why there is a narrow complex, right?